All right, welcome back everyone to another virtual shadowing session. We're glad that you could catch us this Thursday. Today we're going to be talking about cardiology. We're going to be joined by Dr. Adesina. He's a fellowship trained cardiologist specialized in cardiac imaging. I think this is one of our first, if not our first, cardiology session, and I know a few of y'all have been requesting this specialty, so we're excited to bring it forward. I have a few reminders for y'all, especially if you're new to virtual shadowing in general. We just recently started the spring semester, so I know that some of y'all might be new. The first thing I want to say is that we do have a Q&A at the very end of each of these sessions. Sometimes we might have it in the middle, but typically it's saved towards the very end. And that Q&A will take questions from the chat. So you will either see a chat on your right-hand side or below this video here, this live stream. Feel free to type in any questions that you have, and Dr. Adesina will be able to answer them at the very end. Anything about his journey, anything about the cases we go through, feel free to type them in the chat. Also, for those who would like to stay in tune with more virtual shadowing sessions, we have these typically every Monday and Thursday. So if you want to stay tuned for more, we will have more next weekend or next week. And through the rest of the spring, you will know the speakers that we have and the specialties that we bring forward through either our Instagram page where we post our flyers or our email listserv. You could go through both, but essentially they'll give the same information. Both have flyers. So if you want to hop onto our Instagram, feel free to give us a follow and you'll be able to stay tuned. If you want to go through our listserv, this is an email listserv that we send out weekly. So like I said, we do have flyers there. We also have some special announcements on our listserv. We have a few programs outside of shadowing. So if you want to stay in tune with those, feel free to join our listserv. Those are also something that we post on our Instagram, but just not as frequently. And to hop onto our listserv, just subscribe on our website. We have a subscription form at the very bottom of each page on our website. So just enter your name or email, you'll be good to go. Or you can email us at community.h4h@gmail.com, and you'll be ready to go. We'll add you on manually. But with that said, Dr. Adesina, feel free to take it away.
Thank you so much. It's definitely an honor to be with you guys today, especially being the first week of Black History Month and American Heart Month. So I'm definitely honored to be here. So as you stated before, my name is Dr. George Adesina. I am a cardiologist here at Kelsey-Seybold Clinic. I work in the Texas Medical Center here in Houston, where I'm born and raised. And I guess we can get right into it. I guess the first thing is I'm always being asked kind of like, how long does it take to become a cardiologist? But rarely do people actually ask you, how did you actually become a cardiologist and the journey that it took to get there? And I think us in the medical community, it's really important that we have these discussions, we have these talks, because I think it can really kind of change your perspective as to, how people got to where they were, and hopefully motivating somebody to let them know they're not alone. So I'm just going to kind of jump first into my medical journey, and then we'll have two cases of mine that we'll talk about at the very end. So my journey and my life has to always start off with my parents. I am first generation Nigerian American. So my parents immigrated here in the 70s, and they went through a lot. Funny enough, my dad actually wanted to be a physician when he was growing up as well. But coming here in America, he faced so many adversities and struggles, discrimination, racism. He and my mom they literally had to start over so many times. And so me and my siblings, we have always been taught that, you really have to put your best foot forward to get what you want. And they really raised us to kind of understand the value of hard work. And so it's funny because in just one generation, they went from struggling immigrants to now, me and my siblings, my eldest sister is an engineer. My other sister is a school psychologist. And then my younger brother is a lawyer. So we really have, put forth the lessons that they have taught us. I think for me, I've always known that I've wanted to be a doctor. And funny enough, I've kind of been exposed to cardiology my whole entire life. My dad actually, after multiple career changes, he actually became an echocardiogram technologist. And my mom was an EKG tech. So they were two different hospitals. And eventually they actually opened up their own school. So they're now small business owners. And again, it just kind of tells you the will and testament for them. And so even though I've always wanted to be a cardiologist, I mean, the struggle was definitely real, as you can see by these pictures here growing up. I was deathly shy. to the point where literally saying hi to people coming to my parents' house to visit, that was like anxiety provoking for me. So I was such a shy kid growing up, and that really bothered me because I always thought, how would I be a doctor and talking to strangers every day and talking for a living when I can barely say hi to someone that's coming to visit me in my own home. So that was something that I think that was probably one of the first hurdles that I had to overcome. Luckily, my parents and my teachers, they noticed that I could sing. So they put me in a choir almost right away. And so I joined the four-band boys choir when I was in elementary and middle school. And this is a pretty, not to toot my own horn, but this is a pretty competitive choir. If you make it to the top level of this choir, you actually get to travel the world and tour. So I went from being like a super shy kid, being shell shocked and wanting to be at home with my parents all the time, to like traveling the world, going to Mexico and Denmark, and that I think was a pivotal change in my life. And I don't think I could be where I am today if that did not happen, because it really changed my perspective and it really opened me up as a person. And so I went from like not talking at all to like now you can, as you can tell, I rarely shut up. So that really kind of changed my life and really just opened me up to another level. In regards to being a doctor, like, again, I just always knew I wanted to be a physician. I was one of those kids where I literally was sick all the time. So if the flu was going around, if a stomach bug was going around, I literally caught everything, and not only caught it, but like ended up in the ER, like close to like being admitted. That's how sick I was. So I was always around doctors. And again, being, my parents being in the medical field. But for me, I think the thing that stuck out is I would go to the ER or go to the doctor feeling at my lowest. And then a doctor would come in, ask me some questions, give me some medication, and literally change how I felt. And I was always just fascinated with the power that they possessed. And that magical feeling for me was something that I knew I kind of had to be a part of. But as I was looking for mentors, I definitely noted that there was a lack of diversity, especially in my area. I can't tell you how many doctors that I saw growing up, and none of them really looked like me. And that really bothered me. So not only did I have the determination and the desire to become a doctor, I now had a purpose, and that really motivated me to get to where I am. And so from that time forward, everything that I planned in my life and my journey, it was always to lead me to where I am now. So I kind of, stated this is kind of like my journey. So, I always wanted to go to a huge school. I really was going to go to UT Austin. That was what I had. I actually wrote that down, I believe, but I actually ended up going to Xavier University of Louisiana in New Orleans. And this is actually the #1 school for placing African Americans who are interested in medicine into medical school. So it's been like the past 20 years, they are #1 every year at being able to take college students and get them into medical school. And I had never heard of the school ever before. I stumbled upon it because my best friend at the time was applying, and I am so glad that I did. It's a historically black college, and it literally, again, it changed my life. It was probably one of the best 4 years of my life because I was able to be nurtured, I was mentored, and I was really just placed on this course to become a physician. Actually, should probably say the best 3 years of my life, because unfortunately, the last year of college is when Hurricane Katrina hit, unfortunately. So I was there for Katrina. I lost almost everything that I owned, was going through some things in my personal life. And unfortunately, this aligned right at the time that I was supposed to be studying for the MCAT. So if you can imagine, I bombed the MCAT so bad. And not just once, I bombed it twice. So for someone who was getting straight A's. I think I had a 3.9 that semester. I was doing everything that I thought would lead me to become a physician. I bombed the MCAT, and I thought my dreams of becoming a physician were over. Despite my mentors telling me to probably rethink things, I still applied to medical school anyway, being very stubborn. I only got one interview. And literally in the middle of the interview, I remember one of the interviews pretty much told me that I was not getting in. So you could imagine that shattered my world. So everything that I had worked up until that point was to become a doctor, and I had no idea what I was going to do with myself. So my plan B is I enrolled at Tulane University School of Public Health, and I was getting my NPH, and I just was going to, work in healthcare policy and be adjacent to medicine, but not necessarily in it. but I always had this nagging voice, in the back of my mind saying that I need to try again, that I didn't really give it my best effort. So I didn't tell anybody. I put my head down, I buried my head in the sand, and I studied for the MCAT. Literally, that's all I did. If I wasn't in class, if I wasn't at work, I was literally studying for the MCAT. And thank God I finally knocked it out the park. That second time that I applied to about 10 schools. I got 7 interviews and I got into 6 schools. So I literally went from bombing the MCAT, where like they're telling me at the interview, there was no way you're getting in, to getting accepted to almost every school that I applied to. And so after that, I decided to go to University of Texas Medical Branch School of Medicine. And medical school was very hard for me. Again, I was somebody that got all A's literally throughout grade school. I breezed through college, but medical school was such a different way of learning. And I don't know if you all can attest to this as well too, especially, if you're interested in medicine, we're usually type A, we're organized, we have everything planned out. And I was somebody that, to do well in high school, pretty much all you had to do was memorize what was going on and show up to class. And that's kind of how I entered medical school. And that is not how it panned out to be. I really had to change my thinking and not just memorize facts, but understand them and be able to integrate them into my thinking to make clinical decisions. And for me, that was not as easy as it was for everybody else. So I struggled in medical school quite a bit. And so again, I doubted myself the whole entire time, especially knowing how competitive cardiology was. But what I did is I knew I wasn't the smartest person there, but I knew I was the hardest working. So I outworked everybody. Every rotation I was on, every meeting I went to with the mentor, potential attending, I just worked my butt off. And luckily, I matched in internal medicine at Baylor University of Dallas. So that's that picture here in the middle, me in residency. And again, I went from bombing the MCAT to being in internal medicine residency. And I actually became one of the clinic chiefs. I was one of the chief residents there. After residency, I went into fellowship there again at Baylor University Medical Center. And again, I became chief fellow. So again, I'm not the smartest person. Clearly my test scores will show you that, but I outworked everybody, which, helped me get ahead. And after that, UTMB actually recruited me to come back and work there after I graduated from fellowship. So I went back to my alma mater, where I worked as a clinical professor there for about 1.5 years, up until, I was snagged my current position at Kelsey-Seybold Clinic. And we're a large multi-specialty clinic here in Houston. We have multiple locations. It's a fairly large organization, where I actually became the first Black cardiologist that they have ever hired or ever had. So again, it is not how you start, it is how you finish. And I am a testament to that. So anyone who's doubting yourself, if you've had a roadblock that's placed in front of you, just remember, all you have to do is find a side passage and get back on your course. It may not necessarily be easy. It may not be picture perfect. It may not be the 4 years that everyone else is doing, but you just have to find your own lane and continue to excel. So I just want to make sure I say that, because a lot of times people think that I've had it easy, and I definitely have not. So currently practicing as a cardiologist, it's been awesome. I will tell you though, there's this myth that I think we all tell ourselves in medical school and residency and fellowship, that things will just be so much easier after you start practicing. And I think we say that because we just want to get through, the trials and tribulation of training. And that is true to some extent. But of course, there are other struggles that come with being an attending, but I would not trade this for any other job. I have had the best time practicing and the best patients that I can ever ask for. So many patients that I've have been able to help have been connected with me in some other part of my life. My favorite story is probably the picture of the 2 ladies on the right. So I think this was probably my first week of being an attending at UTMB, my very first job. I'm fresh out of training. I'm nervous. I don't think that I'm doing a good job. I'm completely just terrified. And I walk into that picture there, the lady in the purple, that was my patient. And she's accompanied by her adult daughter. And I turn and look at her, and instantly we recognize each other. So she was actually one of the mentors that I had when I was in that choir a long time ago in middle school. So I hadn't seen her in years. And so it was just such a full circle moment. For the last time she saw me, I was this insecure, super shy kid to now being the cardiologist that's taking care of her mom. And so it's moments like this that really get you through the tough times and remind you why you're doing what you're doing. And so again, when you're having these pitfalls, these roadblocks in your journey, this is kind of what you want to hang on to. And this is what's going to take you to the finish line. And so I've been just so blessed to been able to carve a new type of practice for myself. Almost immediately within joining Kelsey Siebold, I mean, I've had so many media opportunities, and I definitely have caught the bug. I love medical journalism. I love medicine and media, and I love the intersection between the two. One of my passions is educating my patients and, letting them understand what their diagnoses are, what the treatment plan is, so they can be participants in their healthcare, active participants in their healthcare. And doing this, especially with media, has really helped in my practice. I've been able to reach people that I probably would have never met before. I've had patients come up to me and say, "Hey, I chose you because I saw you on the news talking about fish oil or talking about high blood pressure." So I've been with Kelsey Siebold for about 5 years. I've been on the news numerous times. I've had multiple speaking engagements, been guest on podcasts, wonderful platforms, as in the one I'm on currently. And it's just been such a rewarding experience. During the pandemic, I just remember there was just so much misinformation that was going on. And I remember me as a physician, I was confused as to what to listen to, what's real, what's not. And I remember on Instagram, I would get so many DMs of, "Hey, like, what's going on? Should I be afraid? Is this real? Does this medication work?" And, at the time, it was like, it was giving me whiplash how quickly things were changing. And so during the pandemic, I actually started an IG live series called COVID Conversations, where essentially I had a doctor on every week. And we just talked about what we were going through as physicians, what we were seeing, what the newest treatment plans were, advice for people to stay safe. And it was just such a blessing. Most of the physicians were people that I went to med school with, that I trained with, and a lot of them were people of color, because as you know, our Black and brown communities, there's so much of a mistrust between them and the medical community. So I really think it's important to have such a diversity of faces out there so that people can turn to. So that's also something that continues to motivate me, the days when I'm tired post call and I don't want to do anything, but knowing that there's people that are not only looking up to you, but they are relying on you. I have so many patients who have told me that they would literally die than go to a different cardiologist. So it's that responsibility, but most importantly, it's that privilege. And again, that's what keeps me going. And that's the rewarding part of being a physician. And I hope that everyone finds that in their lane, in their journey, becoming a physician. So before we get into the cases, this is kind of the last thing I just wanted to talk about is work-life balance. So this is a picture of me and my family. This is shortly after we became a family of 4. My wife actually had our son in the middle of the pandemic. So crazy story, we found out that she was pregnant with him literally the week that the world was shutting down. So you can imagine how crazy our 2020 was, on top of me working in the ER, working in the clinic, being exposed to everything. So this is my wonderful family. My kids are now 4 and 2. And I was the type of person, I did not think that I could be a good physician in addition to also being a good father and being a good husband. For me, I always thought that to be a good physician, that's all you could do and that's all you could be good at. And I'm really happy now because I feel like work-life balance, self-care, the importance of mental health is now becoming a priority. And I really want to make sure that everyone kind of takes that into account. And that is something that you can reiterate. So for me, again, I was a one-track mind. I was type A, super organized. And I kind of had that mentality that I wanted to save the world. And I honestly thought being a family man might get in the way of that. But to my surprise, it's actually the opposite. Being a husband, being a father has actually helped me become a better physician and I think a better person. I'm able to empathize with people in a completely different level. I'm able to look at the world in such a different manner. And honestly, it's actually helped me become more efficient. So I've been able to tailor my schedule where I'm at work and I am 100% locked in, glued in for my patients. But after work, I'm 100% locked in into my family. And it's really important to have that balance because I know that in order for me to be a good physician, I also need to be a happy, healthy, and fulfilled individual. And there was times where, I mean, I would take off of work because, you know, I wasn't feeling well, or my kids were sick, or my kids had an event, and I would feel so bad thinking, you know, I was letting my patients down. But finally, some of my patients finally told me, like, you know what, I would rather you be happy and see your kid in their Christmas program and come in here telling me about it, being fulfilled and being happy to be here, than to walk into work being burnt out, angry, and not wanting, you know, not having that zest to be a physician anymore. So I think that's really important. And I hope right now that is something that's taking a priority in the medical training now. I know for me, you know, I'm pushing 40 now, but when I was training, that was not a priority. And I'm kind of in that gray zone where some of my counterparts that I work with, they just don't understand that notion of you wanting to have a balance, of you wanting to be at home. I can't tell you, there's so many older physicians that told me, like, you know what, I missed my children growing up, or I messed up my marriage because I was never there. And so that's something that I've always vowed against. And so I really want to make sure that I encourage everybody in your journey, when you're locked in, when you're looking, when you're trying to do everything just to meet that goal, make sure you are still having that balance. Make sure you're doing things that you like. Make sure you're doing things that fulfill you. And again, you being a good physician, you being a good medical student, is important that you're a happy, healthy, and fulfilled individual. Okay. So I'll get off my soapbox now. If you can't tell, I'm very passionate about that, because I think that's something that we don't talk about enough. So we'll jump into these two cases I have for you guys. So these are actually two patients that I've seen fairly recently. One was literally in the middle of the pandemic, and the other was a couple of months ago. So this patient was actually from a couple of months ago, and I titled it CrossFit Chaos, which to this day, my office calls him the CrossFit guy, and he does not like that at all. But this is a 38-year-old healthy white male who came to the ER for chest pain. Initially, he noted he was having increased chest pain because he was working so much. So he thought he was just stressed out at work. He wasn't sleeping well. He had some issues going on with his girlfriend. So he wrote it off, just thinking it was nothing. But the pain was actually fairly typical chest pain. It was located in the center of his chest. When he would exert himself, it would radiate down to his left arm. It was associated with nausea, vomiting, shortness of breath. And he had noted that, you know, for the past like 3 weeks prior, he was super fatigued. So he was sleeping anywhere between like 8 to 10 hours per day and taking naps at home and at work, actually, and was still exhausted. He noted that the chest pain was worse with exercise and was better with rest. Despite having this pain, this guy literally was still going to CrossFit because he was repping or preparing for his upcoming wedding. So he really wanted to get in good shape. So he was actually pushing through his workouts having this chest pain, which I don't recommend, by the way. The pain progressively got worse over a week or so. And while he was at CrossFit, he actually experienced severe chest pain that was severe enough, causing him to fall to the ground, clutching his chest, and he nearly lost consciousness. So his CrossFit instructor and his girlfriend called EMS. They were called, they evaluated him, and he was transferred to the ER immediately. So just a little bit more information about him, his background, his past medical history. He was obese. So he had recently lost 50 pounds on the keto diet. So again, he had this upcoming wedding. He wanted to look good for his pictures and for his honeymoon. So he was really getting after it and had recently lost 50 pounds in just a short couple of months. His family history was unknown. Unfortunately, he was estranged from his family since he graduated from high school. So we had no idea what his family history was, what his genetics looked like, or if there was anything that runned in his family. His social history, he was one of the head bartenders at a bar. He worked out 3 to 4 times a week, just a social drinker, and did admit to some occasional marijuana use. On exam, his blood pressure was 150 over 90. He was he was pretty tachycardic. So heart rate initially was 100, but when I was in the room on telemetry, his heart rate would actually shoot up to the 120s and 140s, and he was breathing about 20 times per minute. One of the things that I'm sure you guys are learning about is, you know, the eyeball test. So when you walk in and just look at a patient, you can kind of get an idea of how sick they are. And this guy looked sick. So he looked uncomfortable, and he was literally sweating bullets just sitting in the bed. So you could tell something was going on. So his labs were, interesting enough, his lipid panel was super high. So his total cholesterol was 297. Normal should be less than 200, especially for a fairly young, healthy guy like him. It should definitely be a lot lower than what it was. Triglycerides are 193. His good cholesterol, or his HDL, was fairly low. So we usually want your good cholesterol will be 40 and above, but he was actually at 24. His bad cholesterol was fairly elevated as well too. We usually want to see that below 100, and he was almost double at 200. Whenever someone comes into the ER for chest pain, we always check a troponin level, which essentially lets us know if they're having any heart damage. So normal is less than 0.4, and his was pretty elevated at 22. The biggest thing is this EKG, and this is what caused the ER doctor to page me immediately. So an EKG, essentially, we put electrodes on the chest, and we look at the electrical activity of the heart. And this can tell me what rhythm the patient's in, if they're having any abnormal arrhythmias, and also if they're having any active heart damage. So if you look at this picture on the top left here, this is what a normal EKG should look like. So you have your P wave, your Q wave, RS, and then your T. And so we usually pay the most attention to this right here, which is called the ST segment. So if we're seeing any depression or declining of this ST segment compared to this line here, your PR segment, we usually get worried that there might be some possible heart injury. But when we start seeing elevation, so when this starts increasing, this is what is characteristic of a heart attack, okay? And so if we look at our EKG here, I'm sure some of you are familiar with this. We can look at our different leads. And the good thing about the EKG is the different leads correspond to the different areas of the heart. So leads 1 and ABL usually correspond to the side of the heart, in addition to B4, 5, and B6. So those are what we call our lateral leads. The inferior leads, leads 2, 3, and ABF, those usually correspond to the right side of the heart. And then leads V1, V2, and V3 usually correspond to the septum. So that tissue that's right in the middle of the heart. So as you can see, you don't even have to really have medical training to know that there is some abnormalities here in these inferior leads. So there's definitely some ST elevation. So we're comparing it to this segment here. So there's some ST elevation here. And this is actually what we call the tomb sign, the tombstone sign. So it looks like a tombstone. When you see that, that is a heart attack until proven otherwise. When you look closely, not only does he have this ST elevation, he actually has some reciprocal changes in these other leads. So you can see that the ST segment is actually depressed in these leads as well too. This is never a good thing. But looking at the location, 2, 3, and ABF, our inferior leads, light bulb should be going off that there's something going on with the right side of his heart. So as we know, there's 2 major coronary arteries. There's a right, and then there's a large left that splits off into an LAD and what we call a circumflex artery. And so whenever someone's having a heart attack and we see this, we want to look at that artery first. So we took him to what we call the cath lab, and we performed a procedure called a coronary angiogram. And essentially with this procedure, you can put a catheter in through the artery here in the wrist, your radial artery, or the artery here down in the groin called the femoral artery. And because all of the arteries are connected to the aorta and the heart, you can thread the catheter all the way up into the aorta and then down into the coronary arteries. And essentially, this catheter, we can shoot contrast here and then take like a fancy X-ray, which allows us to look at the artery directly. It helps us to look at the structure, if there's any blockages and everything like that. So again, these are the arteries that we were talking about before. You have the heart muscle here. The 2 small chambers on the top are called your atria. The big chambers at the bottom are called your ventricles, your aorta, and then your coronary arteries, which are the arteries that feed the actual heart muscle. You have your right coronary artery here on the right side, and that's what we were worried about with this gentleman. And then you have what we call your left main that splits off into 2 arteries, the LAD, or left anterior descending artery. So that's coming right at the middle. And usually that's the territory is those V1 through 3 leads. So that septum area there. And then your circumflex artery, which does the lateral portion or the side of the heart. So again, with him, with this EKG, with these inferior leads, automatically we know that there's probably something going on with the right side of his heart corresponding to this right coronary artery. So we took him to the cath lab. This is what an angiogram of the right coronary artery should look like. So you can see our catheter here. I don't know if you guys can see this little blush, this little excess contrast that's coming out. The right coronary artery should essentially almost look like a C kind of. So it's like a elongated C. But you can see the contrast is going through this artery. There's no blockages. It looks great. It splits off into 2 arteries towards the tail end or the distal end. And you have some side channels here that are coming off as well. This is a movie of what our patient looked like. This is what his right coronary artery looked like. So you see our catheter here, that excess contrast that we were talking about, immediately you see the first part of the artery of the right side start to fill up, but there is it completely stops. So you can actually see a little clot here, and there is no blood flow going at the end of this artery. So this angiographically, this is what a heart attack looks like. This is a complete disruption of blood flow of this artery. So that area of his heart on that right side is not getting blood flow, causing that EKG to look like the way it does. So he actually did fairly well. We put a stent on that right side of his heart in his RCA. He recovered well in the hospital. I saw him in the office a couple of weeks ago, and he actually returned to CrossFit almost immediately. Actually, before I cleared him to go back, he literally went right back because he is not playing about this wedding, if you can't tell already. Luckily, his girlfriend was there, or fiance, excuse me, and she gave us a little bit more of info that his keto diet was actually not the best. And so he was fairly strict in the beginning, right? So in the keto diet, essentially you're retraining your body to work on fat. So you're not eating a lot of carbs, and you're eating all types of fat to get your body to operate on that fat. He did that. He lost the 50 pounds, but towards the tail end of the last couple of months, per her words, he kind of went rogue. So he was eating super loads of unhealthy fats in addition to eating bad carbs as well. And I kept pressing them to kind of get a better idea of what he was doing. And he admitted he was actually drinking bacon grease. So he would eat the bacon, save the grease, and was actually taking shots of bacon grease. He was going through multiple sticks of butter per day. Excuse me. And he was eating fried chicken and fast food several times throughout the day. Throughout the week. Excuse me. And so as a physician, sometimes you kind of have to work as a detective. So we can all admit a 30-something-year-old coming in with a heart attack, that's not typical. So a young patient coming in with a heart attack at a very young age, physically fit, very high cholesterol levels, no other real risk factors for cardiovascular disease, immediately my mind was something else is going on. This is probably from a secondary cause. And the two things that I had on my differential were it was either secondary to the horrible keto diet he was doing, or he had something called familial hyperlipidemia. Sorry, guys. I had COVID a couple of weeks ago. My voice is still not back. All righty. So what is familial hyperlipidemia? So this is a genetic disorder that actually causes abnormal elevated levels of your cholesterol. So some of the criteria that you need in order to get diagnosed with this disorder, you have to have an LDL or bad cholesterol above 190, a first degree relative with LDL greater than 190, or a known premature heart disease. So for guys, premature is usually before age 50. Premature for women is usually before age 60. So if they're having heart attacks and cardiac events before that, that is definitely considered premature. So at 38, he definitely falls well within that range. Most patients were able to diagnose them with just getting annual or regular fasted lipid panels with their physicians, with their PCPs, with their physicals. Unfortunately, with him, he hadn't seen a doctor in 15 years. So we don't know if this cholesterol level, if this was new because, again, his keto diet, or if this is something that he's had throughout his life event. Most of the time, this runs in families, so you do need to get first-degree relative screened. So one of his New Year's resolutions is actually to reach back out to his family to make amends and to ask them about their family history so that they can also get screened as well. When we see these patients, again, we diagnose it mainly with the fasted lipid panel, but sometimes on physical exam, you can actually see cholesterol collections. So you can see this is actually a picture of a child with super elevated cholesterol levels with familial hyperlipidemia. And you can kind of see this cholesterol buildup underneath the skin. We usually see it a lot, most commonly, almost every case that I've seen, I see it a lot in the eyes. And so you'll see kind of fat deposits here around the eye folds. And sometimes if you look closely around the eye, they'll have this gray ring around, and that's usually a sign of elevated cholesterol levels as well. So when we do diagnose these patients, the goal of treatment is to get their bad cholesterol levels down as soon as possible, because decreasing that bad cholesterol level will drastically decrease the risk of them developing cardiovascular events later on down the road. Now, the other thought I had was, was this secondary due to his keto diet? So the keto diet, as we know, it's gotten super popular in the past couple of years because a lot of celebrities have used it to lose weight, but it's actually a fairly, it's been around for a long time. They actually used to use the keto diet for epilepsy in the 1920s because they thought the ketones that were developed in your bloodstream would actually help prevent seizures. So this is not a new diet plan at all. It's just something that's, gaining popularity recently. But essentially in the diet, you want a high fat, moderate protein, low carb diet. And that low carb is really important because essentially you're reprogramming your body to not work on carbs and sugar, but rather to burn fat. And so you can't hold on to fat because your body is actually using it for fuel to work. And that's what causes patients to lose weight and helps them maintain a lower weight. Unfortunately, with this, we don't have any long-term studies as to if or how the keto diet might affect patients long-term from a cardiovascular standpoint. What we do know is when a patient starts doing the keto diet, usually we see an increase in the LDL or the bad cholesterol initially. Those usually level off and then start to drop, and then the good cholesterol tends to increase. But every patient is different. I've had patients do keto, especially those that are doing multiple sticks of butter and eating a lot of bacon and not eating the good healthy fats. I've definitely seen their bad cholesterol levels shoot up drastically from normal, like less than 100 to close. I've seen one patient go up close to 300. So it's really important. I usually recommend patients, if you're going to go to keto diet, make sure you are letting your physician know and that someone is monitoring your cholesterol levels to make sure that they are staying within a healthy range. And then, of course, not all fats are created equal. So yes, eating fat as a whole, if you're having a very low carb intake, will allow your body to burn off that fat. But if you can, try to stick to the more healthy fats like avocado, nuts, and things of that nature. I definitely don't recommend drinking bacon grease and not going through multiple tubs of margarine and butter as well, too. So with this guy, it's really hard to tell. Again, he does plan on reaching out to his family and seeing if there is a family history. So hopefully we'll have an answer to this mystery because this is something that's really been bothering me. And I think something that I might want to study in the future, how the keto diet actually affects cardiovascular events. All right, so we'll go to our second case here, which I titled Generation Dragon Ball Z. So this is a 21-year-old male who presented to the ER with sudden chest pain, located in the center of his chest and radiating to his back. He was very on point about describing this pain as a tearing or shearing pain. And he said, again, it would start in the anterior portion of the front part of his chest and it would shoot all the way back to the middle of his back. It did occur while he was playing Dragon Ball Z. So his mom thought maybe he was just getting hyped up or getting, upset or getting excited. So they kind of played it off. But the pain progressively got worse, which caused him to seek medical attention. According to him, there was no obvious triggers or any other associated symptoms. He was a young guy. He worked out frequently and felt fine besides this episode. His mom states that at a young age, he did have a surgery in his teens to correct his abnormal sternum. And luckily, they actually had pictures on their phone to show me. So these pictures at the bottom here, you can see this is a little measuring tool here. You see how concave his sternum is here. And this is after the surgery. So even after they corrected it, he still had a little bit of a deformity, but it was nowhere near as concave as it was before. Oh, sorry about that. So he was a pretty tall guy. So he was 6'7" and very tall and slender. If you look at that picture on the top left, you can tell he had very long arms. So he had a super exaggerated wingspan, even for him being a tall guy. That's the first thing I noticed as he was laying in the bed. And as soon as I saw him, I said, hey, I need you to stand up so I can look at your arms. And he graciously allowed me to take this picture. But that was one of the first things I noticed, again, using the eyeball test as soon as you walk into a room. He was a current college student, no medications. His mom was in the room, but he did admit to no drugs or alcohol use. But again, his parents were there, so I'm not sure how true that was. But his vitals, EKG, and the remainder of his physical examination was all normal. And so they ended up getting a chest x-ray in the ER. And this is actually, these aren't his actual films because his films really didn't, they were poor quality, but this is what we typically see in cases like this. So if you look at his x-ray here, you can see his lungs, you see his ribs here, his heart. And one of the things that we look out for is the mediastinum. And that essentially is the cavity that's in between the lungs here. When it's enlarged like this, that usually means that there's something that's distended or enlarged. And the biggest thing that stuck out for me is, again, this is the heart, and this is the area that you see the aorta. So what we call the aortic knob was very prominent on this chest x-ray. So already I'm having bells that are going off after I'm seeing this x-ray. So after that, we proceeded to get a CAT scan. And so imagine you're having the patient turn to the side. So you can see portions of their ribs, their lungs here, again, their heart. And then the aorta is shaped like a candy cane. So you can kind of see the curvature here, and then it goes down here, and the aorta splits all the way down to your stomach. And then the whole way down, it's just splitting off into smaller arteries. So with a CTA, or coronary angiogram, we shoot contrast to a patient's IV that allows their vessels to light up, so I can look at the vasculature and the structure, particularly the aorta. As you can see, there was areas that weren't filling up like the rest of the aorta. So it wasn't confluent. There was these small pockets here consistent with small tears at the aorta. And this is what we call aortic dissection. So an aortic dissection is when you have a tear in the aorta. And so your aorta is comprised of three types of tissue. The outer layer is called the adventitia. There's a middle layer that's called the medium. That's kind of like the musculature area of the vessel. And then the inner layer, which is called the intima. So an aortic dissection happens when there's a tear in this intima. So instead of blood flow coming from the heart, which is down here, and into the aorta, into all your organs, with the aortic dissection, it's actually shooting through the tear, and it's forming a whole entire new channel, what we call a false lumen. So this can be very, very fatal because, again, your body's not going to have the ability to really get that blood flow that it needs to all of your vital organs. So if you look at the types of dissections, there's actually two. There's type A and type B. So type A is this when you have this dissection at the proximal portion of the aorta, or that very first portion of the candy cane. This is a surgical emergency. And that's because these arteries that are coming off here of the aorta, that's what goes up to the neck and feeds the brain. So you can tell that can be fatal, and patients can pass away from this. So whenever we see this in a CAT scan, that is a surgical emergency. Cardiology and CT surgery need to be contacted immediately, and that patient usually is rushed to surgery. This is very, very different from a type B dissection when it occurs further down after that candy cane. Still, this is still dangerous, but it's not as life-threatening. So this is a surgical emergency. Type B can usually actually be treated medically, mainly treating their patient's blood pressure, their heart rate, and watching them for any clinical signs of deterioration. But there is a vast difference in what you see with type A and type B. So it's really important to look at that CAT scan very closely. So this is what the CAT scans look like for type A. As you can see, that first portion of the candy cane here of the aorta, the proximal portion, here's the tear. So this is the true lumen of the aorta here. This is where blood flow should be going to deliver blood flow to all your organs. This is the false lumen. So blood is coming in through this tear, and it's forming its own new channel, its own new lumen. And it's becoming so much that it's actually compressing the true lumen. So again, this is a true medical or surgical emergency. This is quite different compared to type B, where it usually occurs later, further down the aorta, so after that proximal portion. So this is actually from a different patient of mine, an older patient who had uncontrolled high blood pressure. She came in with pretty similar symptoms as the current patient that we're talking about here as well. And this is what her aorta looked like. You can kind of see this linear tear throughout the aorta here. But again, luckily it was further down. As you can see, we're close to the abdominal aorta here with the kidneys and the abdominal content. So this, I was actually able to treat her medically. But again, this right here, this is a surgical emergency. And so again, being that detective, we have to see what is something that can unify this diagnosis, putting all the pieces together. So the first thing that popped up to me as soon as I saw him was Marfan syndrome. So Marfan syndrome is a connective tissue disorder that causes a weakening of the lining of the aorta. So it can lead to dilations, aneurysms, dissections, and in severe cases can actually lead to rupture. The patients are usually tall and very slender. They have an exaggerated arm span for their height. They usually have abnormalities of their sternum. So very similar to what our patient and what he looked like. So it can be either concave or convex, but they both, they can have several different types of abnormalities to their sternum. They usually have very long fingers and extremities. So you can do what we call the wrist and the finger signs. And so if you have the patient make a fist, if they can put their thumb in, and usually they have a lot of extra thumb coming out. So you can see, I'm trying to do that here. You really can't see my thumb that much, right? The other thing you can do is called the wrist test. And this is not that best of a picture, but essentially having the patient wrap their fingers around their wrists. And you can kind of see, I don't really have that much excess finger outside of making that ring. With these patients, their fingers are so long, they have a lot of excess finger that's leading out there. So that's another kind of easy way. Historians actually think that Abraham Lincoln had Marfan syndrome. I'm sure you've all probably heard about this in history, if not in your health classes as well. And there's some theory that, of course, yes, he died of a gunshot wound, but maybe his wound became more fatal because he had that weakening or that tearing of his arteries. So that's something that's had been a theory in history, and it kind of makes sense. And again, with our patient, all of these characteristics fit. To diagnose these patients, there's a questionnaire that you can fill out called the Gantt criteria, and we can actually send them for genetic testing as well to confirm the diagnosis as well. And so I have always, learned about Marfan syndrome, going back to grade school, and I've never seen it clinically. So this was my first case of Marfan's. And so to do it as an attending, by myself, this is truly exciting and one of my favorite disorders and diseases to talk about. So I think that is all I have for you guys. My contact information is up here on the right, my Instagram, Twitter, Facebook. I would love to connect with you guys, love to hear your thoughts of the presentation. Again, I hope this is motivating. I hope I gave you some information that helps you throughout your medical journey. And I guess we can pause for any questions right now.
Yeah, well, first of all, I want to thank you so much for gathering this presentation together. Like I said, I think it is one of our first sessions. We've had quite a few sessions over the past semesters, but I think it's one of our first for cardiology, and especially at the beginning, the stories you said. We all go through those moments at some point. It just is in different struggles for everyone. So I know at least a few people today definitely needed to hear that, and I really appreciate you for sharing. So
of course.
To start it off, and by the way, for those listening, if y'all want to keep your questions rolling in, we can. We'll go through them in the order that we receive them, and we can hopefully put them all in. First thing I wanted to ask is, working in a multidisciplinary environment, you mentioned your clinic has multiple specialties. In that kind of atmosphere, what do you think are the advantages that it presents, being a cardiologist?
So I love working in this environment. A lot of my mentors were private practice physicians, and the way they practice is quite a bit different. Working with a multi-specialty practice, you have everything under one umbrella, and it's a collaborative approach. And so when I'm seeing, like, for example, I saw a patient today for chest pain and high blood pressure. So I'm going through, my spiel, doing everything I need to do from a cardiovascular standpoint. But I do know, as a physician, even though I'm trained in cardiology, I know that there's other things that are wrong. And she was very highly depressed. And so because I knew her PCP, we use the same EMR. While I'm literally talking to the patient, I was able to kind of send a quick message to her PCP, like, hey, I think this person is depressed. Can you get her in for an appointment? And literally, as we're in the room, her office is calling her cell phone to get an appointment with her. So that collaboration and that being able to have everything under one roof has been one of the best environments I've ever worked in. I think it goes a long way for the physician. It takes a lot of stress and burden off of us. And I think it's excellent for the patient. So you have a much better clinical outcomes when they can get everything. Everyone's on the same page. We're all communicating. It's been one of the best experiences that I've had as a physician.
Yeah, that ease of access is great. Our next question is, and you presented this during one of your cases, other than a blood clot, what are some other factors or symptoms that could be cause for a disruption in blood flow?
So just having a blockage, there's multiple things. So there's kind of atypical things as well too. There's a condition called broken heart syndrome, where essentially patients have a very stressful event, whether it be like grief or anger or worry, and it can actually cause stunning of the muscle of the heart, and it can actually mimic a heart attack. So that's one thing. A lot of times too, especially in women, there's something called vasospasms where they don't have a true obstruction, but the muscle and the arteries are spasming, and it's essentially mimicking a heart attack as well too. And patients who are hypercoagulable and more, prone to have clots, they can actually have a clot from somewhere else actually dislodge into the coronary artery as well. So it's not just coronary artery disease. There's multiple things that can mimic this, and that can cause an obstruction as well. But the way that we're able to kind of evaluate and diagnose again is doing that coronary angiogram, which gives us the biggest bang for our buck in regards to information and diagnosis.
You mentioned being a chief fellow and also chief resident. What were your least and most favorite parts of being a chief fellow?
The least by far is you're the bad guy a lot. And so you have to enforce the rules, you have to make the schedule, you have to make sure everyone's doing what they want to do. The best part for me is, again, I said this before, I was the first Black cardiologist, within my group, and I was the first Black clinic chief, and as well as the first Black chief fellow as well too. So just being able to have that role and show others that it's possible and that it's doable, that's the thing that I think I was the most proud of, is just representing and, again, just fighting for diversity. Being in that position, I was able to be in a lot of admin meetings, and so I really pushed hard in regards for disparities within our minority populations. And when it came to issues that were within the fellowship or within the residency, pushing the envelope in regards to making sure that we were being conscious from a racial standpoint, decreasing things that may have some hints of racism or discrimination. So that was probably my favorite part, and something that I still try to do this day.
Bedside manner is something that I'm sure a lot of residencies look out for, fellowships look out for, and what they even look out for as soon as medical school, when you're going through the application cycle, especially around interviews. For you, having gone through all of those steps and now practicing, how do you approach patient care, especially when you're communicating a serious illness, a serious diagnosis? I'm sure there's plenty of times that you can recall, especially with cardiology, of that.
Definitely. And I think for me, especially with my heart failure patients, with heart failure, the mortality rate is so high. And so sometimes having to break that news to patients that, that were probably reaching the end of the road is probably the hardest discussions I have with patients. Unfortunately, there is a stereotype that a lot of cardiologists don't have a good bedside manner, where, and I'm sure you guys probably know this as well too. There's one of the myths or the thinking that a lot of surgeons or people who do procedures aren't the warmest or friendliest, or don't have, bubbly personalities. And cardiology, because we do so many procedures, we're kind of more in that kind of proceduralist type of personality. But for me, I treat every patient, you have to just treat them like they're a regular person. Speak to them like you want someone to speak to your mom or your sister or your dad. And at the end of the day, even though, I'm a cardiologist, I have all this training, I'm still just a regular person. And that's how I present myself to my physicians. I don't kind of talk to them like I'm above them and you have to do everything that I need to do. I usually educate them on what's going on, what our options are, and we make a collaborative approach of what we need to do, so that I'm still respecting their wishes of how they want to live their lives, but also giving them the background and letting them know what the consequences of certain options are. So that's how I kind of do it. Even as a physician, I've had times where other doctors have talked to me like I was stupid or I didn't know anything. And it amazes me that people approach people in that manner. And I just think that there should be no place for that in medicine. And hopefully you all take that to heart. And I hope that you do that as you go further in your careers as well too.
You mentioned that you decided on medicine from an early age, but when do you specifically decide on cardiology as a specialty?
I think for me, I'm a long distance runner by trade. I ran cross country and track up until college. And so I've had palpitations for the longest time. So I had to see cardiologists myself. And I just think I caught the bug. It's just something that I've always been amazed at. Especially like in biology, like just seeing how small the heart is, but it being I guess maybe second to the brain, but being like probably the most important organ, that's always fascinated me. So I knew fairly early on, probably like in middle school or high school, probably.
And I think we'll wrap it up with one more question. You mentioned that you had some struggles with the MCAT, but prevailed in the end. So one student asks, what are some study tips that you have looking back on studying for the MCAT and also getting through medical school?
I think the biggest thing with the MCAT is I built it up in my head as this like impossible, hard task. And you just kind of have to look at it. You know what? That this is just one step, one thing that I need to do to get to the next step of my journey. Approach it that way, but also take it serious enough where you are dedicating the time for it. And so for me, I know I did not study the way I probably should have. Everyone around me was taking review courses. I refused. I thought I could do it by myself. I highly recommend taking a review course as well. And there's actually like quizzes that you can take, especially if you talk to the review course, the person that's running it. They can kind of let you know how you think and how you study and give you tips on how you can change that and really make it to your benefit. In regards to medical school as well, don't memorize. I think a lot of school leading up to medical school is memorization. That just does not fly in medical school and in medicine. You have to be able to identify and recognize something at a 360 view. So in every single form, every single variant, and most importantly, you have to put pieces of the puzzle together. That's if you approach your thinking and your studying like that, you'll be 100% fine. There are so many different roadblocks that get placed, especially in medical school, like step 1, step 2, and step 3. And again, it's so anxiety ridden. I think every school, every student probably feels the same way. It's like this impossible hurdle. It's just one thing you have to do to get to the next step. Look at it like that, crush it, dedicate your time to it. If you are not doing well, like on practice questions or quizzes, I highly recommend talking to someone because you just might need to change your style of thinking and studying. And there's resources for that as well too. So don't be like me and try to be stubborn and just kind of beast through it. Really approach it in an intelligent manner and an efficient manner so you can take it one time and let it be in your rear view.
Well, I think we'll end off the session there. That's some very, very useful advice because I know a lot of people are taking the MCAT this right now. They're studying for it or taking it because application season is coming up. So you got to plan a little ahead for MCAT. So I'm sure a lot of people will hopefully take that to heart. And I know even being someone who's going to be going through that process right now, I'm studying at the moment right now, I'll be taking it. I know that it is definitely a beast of an exam, but at the end, it's just us kind of amplifying what it really is. In the end, it's just 7 hours of your day dedicated to putting down the information that you studied. So
it does not define you. It does not define you. I let that bad score define me for a very long time. And I thought that when I would have success or do well, I would always go back to that thinking that just thinking that I didn't deserve it because of how bad I did. Do not let that define you. That is not who you are. It is literally a standardized test. It will not tell you how good of a physician you will be. It will not tell you how good your bedside manner will be. It will not tell you how successful you are. I have multiple friends. We all bomb the MCAT and we're all leaders in the field of medicine right now. So do not let that score define you.
Mm-hmm. Absolutely. It's an inspiration to look up to people who've gone through the process like yourself and gone on to success, even with the hurdles there. But I really do appreciate you for gathering this together. I do have some last reminders for those listening in. We just posted our quiz in the chat. So for those who would like to earn credit for their attendance, you must pass that quiz. It's a Google form, 10 questions. You need to have 6 or more of those correct. And those are going to be about what Dr. Adesina discussed during today's session. So if you need to replay the session, feel free. But it's going to just be about today's session, about cardiology as a specialty. Like I said, 6 out of 10 questions or more to receive credit. And credit will be in the form of a certificate. That's how you can document your attendance. Some have asked about how hours are tracked. You just add up your certificates and that way you can actually track your hours. Outside of that, we don't have a system in place to track total hours. It's just a per session thing. So for any of you that had that question, feel free to, or that's just the answer there. And feel free to let us know if you have any other questions. Our email again is community.h, the number 4h@gmail.com. Another thing about that quiz, it is on the chat box, but it's also on our website. So if y'all want to hop onto our website under the virtual shouting page, we have the quiz. We have a Monday quiz on the left-hand side and the Thursday quiz on the right-hand side. So click that Thursday quiz, click the button, and you'll be guided onto the same Google form. That's going to be next week on Wednesday, February 8th at 11:59 p.m. Central Standard Time. Like I said, we're going to be continuing with even more sessions. So next week, we're going to see Dr. Sammy. He's an otolaryngologist and the fellowship director for skull-base surgery at the University of Cincinnati. I think this is going to be our first session also for this new specialty in otolaryngology. I'm really looking forward to that session. That's going to be on Monday, February 6th. Like I said, typically it's a Monday and Thursday schedule with our sessions if you're new, and you can follow us through Instagram or join our listserv by subscribing on our webpage or just emailing us. Both are great ways to stay tuned with more sessions. But with that said, Dr. Adesina, he has his contacts here, he has his socials, so feel free to give him a follow. You mentioned your series earlier that you had on Instagram. So I'm sure there's a lot of content on there if y'all want to give him a follow. We really do appreciate you for your time and also for getting this all together. And I really do appreciate y'all for listening in. We'll see you next Monday. All right. Take care.